Okay.
Hey, Samit,
Yes,
can you hear us,
greetings.
Samit?
Very well. We can hear
Dr.
you.
T, how are you?
Yep.
Yes, good. Good
And
afternoon, everybody.
Well, welcome. You've got your audience here. You've heard the panel. Dr.
yes,
Jazz and I are up here as moderators.
beautiful.
Uh,
Let's
Dr.
just
Folkestone, Dr. Thompson, Dr. Yee, and Dr. Magdi.
okay. So let me just quickly take you through because we got our 45 minutes. Very interesting case which wanted a left main with a controversy, not a straightforward one stent versus two. Come out of the ostium a little bit. Okay.
Let me
So
wire it.
these are our disclosures which are nothing. So this is our Arch Live case. Your 85-year-old female. Very interesting actually. She didn't see doctors too long. Otherwise, some for sugar general practitioner and was admitted about a few weeks ago, first time for progressive dyspnea and then acute heart failure with preserved EF. Two, three times ventricular pulmonary edema, troponin remained negative, BNP was elevated. And then patient did the echo was near normal. Then they actually did a stress test. She still didn't want much to be done. Despite that, because of that, then she had an angiogram. So risk factors we showed on the left side. She had little high LDL, should be less than 55 with the CAD. But you know, somebody lived at age of 85. I'll give that credit for it. That LDL still remain less than her age. But clear cut was the uncontrolled diabetes. She was admitted with hemoglobin of 10, A1C of 10.8, then became 9.8. So was put on medical therapy. You can see here. Then she had a cath, which is the two vessel disease kind of which we'll show you with a near normal ejection fraction. Syntax score of 26 and EF was 57, as I said, but little moderately frail. So STS risk score came 5.1 and had a discussion. They felt that patient should be better for go for high risk PCI. And that's where patient is here now. And we'll just show you what it is. Anu, show it now. Go to the angiogram. And then I'll come back to our completion of our presentation, which we make appropriateness. Yeah.
Okay, so this is her LV.
Good.
Yeah, EDP was 8, normal LV function. This is a right coronary artery. You see some calcium, but essentially non-obstructive, maybe some moderate disease in the distal part of the PDA.
Yep.
We can show some hemos at the bottom. So this is a dry cine showing tram track calcium from left main to LAD. So you have significant left distal left main and ostial LAD. And I think the ostial circ is also involved, but you see in the cranial view, you can see that ostial circ is involved, and this is where we are.
But do you have the aleocaudal view or no?
This is the
So if we were
aleocaudal.
going to be,
Yeah.
if we had our heart team look at this, we would
Yeah.
say, they would say one thing like, "You've got great distal targets,"
Yep. That's true.
but you're saying that she's disqualified on the basis of frailty.
And the age also, you know, 85. And you remember this, the patient who didn't want to go to the doctor. And she has been just, hasn't seen a cardiologist, never had any cardiac workup before. And this all came to her as a surprise. And even in hospital, when agreed for further testing, particularly angiogram, after they did the stress test showing ischemia, global ischemia, and she had 2 episodes of pulmonary edema in hospital. With a negative troponin. Although you see that LAD, to me LAD looks a kind of a TIMI 3 minus flow. So this patient just, but very significant lesion in the LAD. I'm surprised that there was no troponin positive on this particular case.
So, Samin, so did you guys, so you measured EDP and
Yeah.
EF was very normal.
Yeah.
Is that why you decided not to do protected
Yeah,
PCI?
that is exactly correct. So question basically was that I was actually very much surprised. I said, how can it be such a bad left main? Let me take back that left main disease. So for everyone, and you know, we engage, and all of a sudden, we had the first tracing. The blood pressure actually, there is significant left main pressure from 140 was 80. So there is maybe ostial, maybe just there, significant 95% left main and almost subtotal LAD. And I personally, I didn't believe that EF will be normal. So we brought the patient this morning because patient came in only as an outpatient, was discharged few days ago from there and came today This morning we did the echo. Our echo says same thing. Normal ejection fraction, little calcific aortic valve. Everybody had little mild MR, but nothing with a normal EF. So exactly what we found on the LV. So therefore, the question there is that do we need to do any support, particularly I would say that that's a very good point. That if there was a more complex osteal circ disease, even with the normal EF in this particular case, I probably will put a impala. But since the looks like circ is okay or may have some disease, which we that will be part of our discussion, and I think we'll decide after I would not do an imaging baseline. I'll do a little rota of the LAD left main, and then do imaging to decide if anything of the osteal circumflex. Then we make it a 1 versus 2 stent, and of course you have a discussion. But because of that, all those factors, good blood pressure, normal ejection fraction, normal EDP, we decided in this 85-year-old patient. Now she does, they were a little worried about her peripheral artery disease. They did some testings there, and it was no proximal obstruction. She may have some distal obstruction, but there's no proximal PAD.
But Jazz, this in a complex left main with that kind of calcium, if somebody says that they want some kind of support, then having a balloon pump probably is not a bad idea.
Yeah.
I mean,
yeah, no, absolutely. I think this patient is so preconditioned because if you see your guide and your blood pressure is so ventricularized, if this patient was EF was low and he was not preconditioned like that, it will spiral down like aortic stenosis patients, and patient would not come back.
Yes.
These are the people you need support in, and here you already proved that the EDP was low, ejection fraction is normal, and the patient is tolerating that ventricularized pressure so well. So I think your decision was correct. But Anu is right. If you're doing complex things like this, if you see any hint of number one, complexity, you want to do atherectomy, and your ejection fraction is low, and acute coronary syndrome patients, you need to put support in, otherwise you'll get in trouble. So that's great.
Yeah, and we've also referred to this as the time to decompensation. I've used this term before, TTD. And you've got a good ejection fraction, but you have a large distribution. You're going to do some rotablator, so there could be some LV dysfunction. But you do have such a great robust pressure that provided you're careful, continue to be careful with the ischemic portion of it, that things should go pretty well. There's nothing wrong with getting contralateral access.
Let me go.
Dr. Keeney and Dr. Sharma said you could put a balloon pump in if you needed to for early prophylaxis, but I think as long as everything stays the way they are, I would just let it go.
Good. So we have a 1.75 bar. It's a rota floppy wire, and we are ready with the 1.75 going to 3 steps. Same with the bar. Do the Dynaglide tap.
Yeah. So what we did was just move this black knob backward forward. Any tension between the Teflon sheath and the wire is gone. Y connector again backward forward. You see that?
And pull back. I think burrow a little back. And the guide even. Yeah, good.
What speed are you going to go at?
150 now.
Yeah, we go with the 150 usually. But yes, we say that after 5, if it doesn't go, then you go to 180. But 150 we found quite good. Let's just start now.
So you see the guide is out. Guide is outside. The burr is just at the ostium. You see that? So we'll start burring from there. And we know that that's guide is outside because your blood pressure is not damped anymore.
Yeah, that's very important, and I think Anu will show you technique, but I think when it is like that, you want to make sure you are coaxial and out so that you don't dissect the cusp. People have caused severe AR and dissected the cusp when you start doing it, but here you see the technique. It's very, very important really that you are adjusted and you are coaxial, you tug on the wire to make sure there's no jumping or anything like that. So the technique is very, very important, especially when you do that. How did you decide on rota versus CSI versus shockwave? Because you didn't image ahead. With imaging probably won't cross.
Yeah, won't cross. Yeah. So question was, I would say in this case, I would not go with the IVL directly, because this one will not even cross. So only question is OA versus rota. So I think one of them could be okay. Both will be okay in this situation because it's not a tortuosity segment. Those who are good with the OA want to use OA, nothing wrong in that. Good. Good. So,
And I guess
and
the
we'll ask you about what has been your impact of the Eclipse trial in your lab. We used to have, in terms of atherectomy, we used like 80-20, 80 rota, 20 orbital. But since last November, after the TCT, it's like 95-5. 95 rota, 5 orbital. Fellows still want to learn orbital, which I am okay with that. And we are doing it more for their learning, because they may go to a practice, there will be only orbital available.
I think I'll stop
So
there.
just a couple of points here.
Yeah.
I think, many people would have done a 1.5 burr here because the length of the calcified lesion is so long. But experienced operators like this can do a 1.75 with the meticulous type of technique they're using, allowing the distal bed to perfuse.
Yeah.
We always say, try to avoid decelerations. What does that mean? You don't want to drop more than
Drop it,
5,000
stop it now.
RPM. Don't wait
See
to
that?
see it on the tachometer. You
Right.
listen for it.
That's
Right?
good.
If it shows up much earlier, they've already gotten through.
Yep.
It'll show up earlier by listening to it than it will when it registers on the tachometer, which is only sampling like once every second or so. So
Good.
here,
Get the run through.
1.75 over a long lesion.
And let's
they've
put a
already gotten
fielder on the
through
circ and
and,
do IVUS.
They're looking like they're in good shape.
Fielder in the circ also, and then do it. Yeah. So we are coming out with a 1.75, and this is time. What we are going to do now. So we are going to wire the LED side by side, and of course the rotor wire will come out after that, and then put a fielder wire in the circ and do the imaging. While they are getting ready, let me complete my presentation, which we always try to do. Go back to the slide.
I just want to insist on the point they made about burst selection without imaging, because it was right. Yes, we selected 175 because it was mostly left main. We wanted to make sure left main was 175, but subsequently when we were in the LED, you saw there was some more. We had to do at least 3 runs there. So in that situation, you could have probably considered maybe 1.5 was probably the right choice, but rightly said, the discussion was the same, that if you have a long lesion, even if it is significant disease, to avoid distal embolization and all these things, it's okay that you go with the smaller burr.
Okay. So, and
You guys,
yeah, sure.
Can I ask you a technique question? Because it's come up with several other operators during the course of this procedure, some of the live presentations. Many people are doing their polishing runs at a lower speed, trying to get a little wobble in the rotoblader burr and get an additional, some additional cutting, like going down to 130, 140,000. Do you subscribe to that?
Yeah, no, I know there have been one publication from Japan, but we personally know. But yes, I think once you have selected, and particularly now, we all know once you need to combine with the second and using that IVL, that will be the good technique and other things. There are some, imaging data on that, but we are not adopted that policy, because we are doing the burring at 150. To begin with. So with that note, and I'm going to come back, and so basically we still go with the hard team, STS risk score, syntax score, and the STS other thing, which is the frailty, cirrhosis, malnutrition. This, the frailty says from 1 to 8, he's like put out about 5 and taken all things together. His score was 26 and STS score is 5.1. So based on that, so now we come back to our OP criteria. We don't have any update on that yet, but this patient will be high risk with a diabetic, with the M, but we know after hard team discussion, that is becomes appropriate, and that actually has been, and then one of those devices we have talked about in this particular case, and this is where we are with the protected PCI, but this will not fall into because of the normal ejection fraction. So coming back to the point with the Jess, and you discussed that if a EF is more than 40, what you do? One thing for sure, now in the complex PCI, even with the normal ejection fraction, Impella is indicated. So in the past, 4 or 5 years ago was not possible, but now there is a clear label that EF with a near normal, but as long as it's a complex PCI, and more so with the after hard team discussion, Impella is okay. But in this particular case, we needed to do, in our any consideration, we probably would have gone with the balloon pump only. And as you know, that Impella trial is just about completion, about 70 patients left of the 1200 with a Protect 4. a trial which is on just about completion here. So we are with the 75, number one. Second is the German center is number two with a 73. We very close, and of course, about 70 or 80 patients are left. But this will be the definite trial of these complex cases, EF of less than 40% or 35%. Now, actually, they made 30%. So, key, but whole point is that we don't have a good long-term trial of these, because even in the Protect 2 and all, there were 90-day outcomes, and so now this is the 3-year outcome, where at least the last patient enrolled will be 1-year follow-up. So the data will not be available before next year TCT or AHA. And then this is the calcific algorithm, which they have chance, will talk about it. I just wanted to say on this point is that this will, in our appropriate guidelines point of view, that this will be still the class 1A, because heart team discussion, patient is not suitable candidate for cabbage with the left main, and there we say either you do a medical therapy kind of palliative if you think nothing could be done, or you can do PCI, and that is what we selected in this particular case. Anu, tell us what you have.
Yeah, can we show the
Okay, now we are with the IVAS.
Okay, start pullback. It's a Boston Scientific Avigo Plus. It's coming pullback speed 4. Yeah, so still 360 calcium peroxylate. Now come to left main. Yeah, I will stop it. So we'll show you.
You should analyze this first before you go to sir.
Sure. Yeah, still proximal LED has a 360 calcium, MLD like 1.8.
But is there a cut into that full calcium,
so
or no?
This part not clear. Maybe after shave, but still 360. This we didn't do balloon, so we don't have a good fluctuations. And this is a distal left main. Yeah, I see the shaved surface of the calcium at the distal left main. This part, the calcium is shaved.
But go to the proximity near the septal.
Sure.
I think we see.
So this is the proximity. Now go more distal. Yeah,
Yeah,
I see some
see
first
that?
blanch.
Yeah. So there's a fracture around that area. So
Yeah, after that is still tight. This I mean.
after that is still tight.
Yeah, like between the septal and the diag, 360 calcium still there.
Mm.
Yeah.
Go back. Show me that calcium again.
So this is between the septal and the first diag. But we just did a
one thing about using a 175 burr is it makes it nice and easy for the IVUS to get through.
Yeah.
Yes.
You don't have to do any pre-dilatation. You can decide upon what your next step
Go
will
to the
be.
sir.
Even
Go to sir.
IVUS
Circumferential calcium.
Yeah,
No.
I think there's an area you cut it nicely in the left main and the
Yep.
proximal, but very close to the proximal and the ostium, there is still pretty bad 360 of calcium that I don't know if the rota touched or not, but you
3.5 IVL.
and fractures distal, so maybe time for some lithotripsy.
I would,
action.
yep,
Oh, I would image the circumflex also now.
we are doing it now. We just heard you, and Anu is ready to image the circle. Let's go to caudal view. Wire is there, and IVUS catheter is ready to go in.
Yep.
And I think that, as we discussed, that this is an important issue, because now that if truly disease, 3.5, if truly disease of the ostium, or the plan, a lot of people go with a stepwise provisional with the EBC 1 or.
So before you say 3.5, let's go to the imaging criteria, how you pick the size of the IVL. Okay. Let's go to the where that tightest, where we saw the circumference, right? And then you get us the vessel size.
Yeah.
Okay. The vessel size, you're saying EL to EL is 3.6, right?
Yes, this is the proximity.
Yeah.
Exactly.
And then
Left main is like a 4.5. Now we go to the circ IVUS.
IVUS is in the
good.
circ now.
Yep. Okay, I start pullback. Coming.
My angiographic assessment was no ostial circumflex disease. But let's see whether I'm wrong or right.
there is disease.
Yeah, there is definitely disease.
I thought there'll be disease. Let's go back.
But not
Yes.
bad. I don't.
No, I mean, we know the mild plaque. Question is, by criteria of the less than 4 millimeter square, will it be a 4 millimeter square or not? It looks like nothing.
No.
Why?
I won't say nothing. There is.
No, nothing means.
Not that, because now once you start intervening onto the left main, you'll start seeing. Now you can say she's elderly lady, do a single stent and leave everything alone.
Well, let's take the vote, Jesse and.
Okay, hold on.
Let them take the
Before
vote
they
there.
vote. Go back to that.
Let's say the panel. What
Yeah.
would they do? You
Yeah.
know, for me, I think the lumen is good enough, but it is high risk bifurcation because because there's calcium, and once the calcium fracture happens and your carina moves, then your circ might become. But I would still do single stent thing in here after you do lithotripsy.
What does the panel think, Dr.
Yeah,
Magni?
let's think about panel.
I think trying to use one stent is the best option with this heavy calcification. You are not sure what two stents can. Maybe you will not be able to do a perfect bifurcation stenting in this case. But my question to start with, why this patient with this heavy calcium and she only started to complain lately with pulmonary edema? How come that? Do you think that something recently happened in the left main?
Or ostial LAD, proximal LAD, I think definitely left main. Yeah. So she could have a little plaque rupture on top of the calcium, because you're right. At age of 85, you present first time in pulmonary edema without knowing the CAD beforehand. I mean, this is amazing. And not only that, I would say it's a lucky, because a little more than 90% left main.
Anything?
Yeah, little more would have been a
area.
big trouble. I mean, even if those kind of patients have a vessel occlusion, it will be very tough for them to be saved.
Dr. Coverstone?
Yeah.
Yeah, I think that circosteum is big as far as minimal lumen area. The calcium is eccentric on there. I think I'd plan for a one stent technique, which is paying attention to it after you balloon it or after you stent it.
Dr. Yang?
Yeah, I think it's because the also R6 there is the lesion is very focused. So it's one stand must try to use the to one stand. If you use the also R6 is not big enough, maybe we can use the shockwave and the R6 use the DCB and the one stand to then the LED to the left main.
Dr. Thomas?
But there's some data saying that if the IVUS plaque burden in the circ ostium is more than 50 to 60%, then there's suboptimal result is possible. But having said that, looking at this, after the lesion preparation is still quite okay, I would consider a procedural strategy for the circ as well.
Okay, let's see what is the plaque burden, Kiski. So just wanted to introduce our team also. Kiski is on the IVUS, imaging, and we have our two fellows here. Frank and Gaurav, and then rest of our staff, our cath lab team. You see a lot of familiar faces. CV, our
have a discussion on the panel that gives you a chance to prep the shockwave.
Yeah. That is true. So we are doing the now only question. We are not touching the ostial circ. I know with the if we go with the concept of the EBC main, you have to do after the stent across. You do a kissing balloon every case. So our policy has been a little different, like learning from that Excel trial that if your one stent approach and your side branch looks good, don't do a routine dilatation. Because those were later on has a kind of non-significant a trend towards little higher stent thrombosis, because no matter how you do kissing balloon, pot balloon, you always distort the stent struts, and they are the one where the trouble happens later on. So key is our strategy a little different than EBC main. EBC main, as you know, after putting a stent, every case they post dilated, did a kissing balloon and pot, and then decided in 22% require the second stent. Compared to the DK crush, yeah.
So I mean, we've had a couple of live cases from Europe, and many of the approaches here have been with a DCB on this side branch.
I know that's another big one. Well, my only question is, I'm still not happy, or somebody has to convince me the data of the large vessel with a DCB. The only one big trial which we have, REC cage free, 3 just showed that large vessel DCB is inferior to DES. And till I would say side branch or less than 2.5, 2.75 maybe, yes. But if you have side branch of 3.5, show me a data, any trial which has shown that DCB will do better than DES, even in the bifurcation lesion.
Yeah, no, I agree. I think it's attractive for people to say, well, listen, I'm going to DCB side branch and do the stuff. But here, the lumen is good. You probably don't need to treat. The only thing I think, and Anu will show her app, the algorithm becomes is when you have definition criteria and you have a high risk calcium bifurcation, you run the risk of changing the carinal angle and making the sex. So what I would probably do is provisional, and if you don't do kissing, I would probably, big circ, I would probably do physiology through that just to make sure that you haven't changed the carina to make it ischemic. That's
Okay.
probably what I would do.
Okay,
But
down.
I think this approach is perfect.
So right now we are they have given 2 cycles. We'll do about four, 5
Go here.
cycles into this. It's a 3.5 IVL. And so question is, people are saying that keep low, don't even go to 6 atmosphere, go 4, and after cycle, once the green light comes, go to 6 and then deflate. But we, in large vessel, we are going to 6 atmosphere. What has been your practice?
Down.
Yeah, I think we start low and
Yeah.
at the end finish up with a 6. The question
Yeah.
here would be, how long can you keep the balloon up without having some hemodynamic compromise?
Yeah.
That's a big question. Yeah. And same thing, you saw that hemodynamic blood pressure rapidly goes down from 110 goes to 80.
Yeah.
Yeah. But then we have the will, and our nurses are all ready. They will give automatically the
Down,
injection
down, down.
to increase the pressure by itself.
Yeah, sometimes when you do left mains like this and when you do lithotripsy,
Okay, go
what
up
we
here.
do is you do one inflation, and because the balloon profile changes and you're still ischemic, your pressure drops, we usually sometimes have to pull the balloon in the guide, let him breathe,
Yeah.
and then do it again.
And that is
so
exactly she did. Yeah.
yeah,
Well, you'd like to get a few inflations before you do that because sometimes it doesn't go back down.
That is true.
yes, absolutely. And then, the key with high pressure here, what happens is I think prepping the balloon and re-prepping is more important than going up to 6. Your higher risk of rupture, the higher you go. And then
Go
it
up
probably
here.
doesn't do too much extra if you go higher pressure. So I think prepping the balloon actually and doing it again after multiple things, you run the risk of decrease the chance of rupture and increase effectiveness of the shock
Okay.
wave by at least
Get
30 to
diverse again.
40%. So I think we are now
Let me
becoming
give one more
very, very
insight.
methodical in prepping the lithotripsy balloon and not going higher pressure.
So even
Yeah.
little things like not just pulling negative on it for a long period, but actually hitting it and tapping it fairly hard to get some of the bubbles to come back
Go
out.
again, go again, go again.
Doesn't
Hard
go.
to get it out of there.
Well, go again.
Simple.
And that's key
Yeah.
because as Jazz mentioned, it can drop. You look at the energy distribution; it drops off rather precipitously.
So actually
think
that prox to mid LED where we saw the calcium, I would say 360-degree, almost like a ring. That's where I think exactly this worked well. I'll show you. There, you see that?
Yeah.
That dog bone was gone. Yeah. So we are going to
Dr.
IVUS
King,
again
were you
and
able to
see
get
it.
were we able to get all 120 pulses in?
No,
No.
70, half.
Only 70 so far.
Because you see there was so much EKG changes every time we do it.
And blood pressure.
Yes. blood pressure
140
was
goes
down.
down to 80. Yeah. So now
the
question
point.
is, what is
You
the
don't get 'em.
Yeah, let me ask you now. I know we are doing the second IVUS run. What the second IVUS run going to tell us? We know angiographically you have done the IVL, stent balloon has been expanded. Why not just stent it?
No, you can. But what we are going to show that IVL definitely has changed that a ring of calcium. The plate has to be that we have a, the IVL has definitely cracked that.
Yeah, so
That's what we are going
IVL.
to show.
Yeah,
This is a
data.
practice.
Yep.
It's very important. Sometimes, even if you do it, I had a case the other day that I was doing. We did IVL, 120 pulse, everything. We
Okay,
did
check the
iris.
image.
There was no fractures.
Okay,
and
start
actually
with a
very eccentric lesion. So
Coming.
we had a very, very hard time. So we had to take an angioscope at
yeah.
a very
I
high
see some
pressure.
fracture. Yeah, nice
Really
fractures.
cracked even after lithotripsy. So I think doing imaging here is
And a
very
nodule.
important because that calcium is pretty thick.
So
Okay.
do you think angioscalp or Wolverine balloon post IVL may help?
No, I think if like in this situation, you see that just we saw that. Actually, I did not senate. The tight area after we did the IVL, the dog bone effect was gone, which means that it definitely has done some kind of a modification. In that situation, we do not post. You can just go now. Now we have done imaging, but even suppose we have not done imaging, you've seen that kind of a IVL effect, you can just go with a
3.5,
stent.
38,
You don't
3.5,
need
38
to go
Zymes.
back with a high pressure balloon again.
Yeah. So that's a good point. So no, I think the point, the question we just asked was very important. If your IVL had not cracked the lesion, Then only you'll go to those adjunct technology of the high pressure or go to score flax, angiosculpt and cutting balloon. But if has fractured the lesion, your dog bone has disappeared. Then I think what Anu pointed out, just go to the stent directly now. Now we also know of the various ablative technique. IVL is the one which causes maximum the fractures, and you see it now, right? Multiple
Yeah,
multiple
now he
calcium
can.
fractures.
He's showing that. Remember that 360-degree
Yeah.
complete plate of calcium. You can see a fracture now.
Yeah, 3 to 4 o'clock, there is a calcium fracture. Other part also have some
A
calcium
lot of
fractures.
fracture.
Yeah.
Yeah, you
Yes.
didn't see that before, so I think yeah, he did his job.
Yeah.
So how the issue was same? It
3.5,
was
38.
tight, 3.5.
Yeah.
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 38.
Yeah.
Yeah.
So
It-
EYE IVUS is telling us 38. What does the IV IVUS tell us?
Yeah, the 38 is perfect, but this vessel reference is actually 3.1 vessel. After the D2, the vessel size down, like a 3.1. If you do 3.5, I think it's better gentle pressure. But
Yeah.
definitely left main is like a more than 4 low. Huge size gap, and approximately is also 3.5. So huge size gap.
And we can take a 408, right?
Yes.
And 408. And remember, anytime when you put a stent in the left main, always think few millimeter more. Because if you're planning to do a pot and you have only 2 millimeters sticking in the left main, it's not enough. Because then you go to the large vessel into the proximal LAD, may cause rupture. And we have seen few cases in the live about 1.5 years ago. I was moderating a case in from India. So clearly in this particular case, you want to bring a little more, although here you can make it a point of bringing up to the ostium of the left main. But otherwise, the point is when you are doing a distal left main only, but try to bring the stent to the mid left main, and if there's no ostial disease, so that you have room for your pot balloon. As you know now, there's a separate pot balloon is available, which is the 6 millimeter and shoulder to shoulder. There's no neck. It's exactly horizontal balloon. So that you don't have to worry about overhanging edges in any segment to worry about dissection. It was been used in India quite a bit, and now actually just came to America about few months ago.
So, guys, on your injection there, it's interesting. There seems to be a linear tear there that's pretty deep
Yes.
into the wall.
Yeah.
I know. So that's what I wanted to. Did you see it on the IVUS?
Nope.
I mean,
Well,
a lot
we
of
truly appreciate it.
Yeah.
We see it on
Proximal
IVUS, we only
LAD.
see it on the injury.
Yeah.
Show that
Proximal
angiogram.
LAD.
Show that on angiogram so everybody
I think so.
appreciate that.
Of
Yeah.
course, calcium artifact can like hide that lumen, but
Yeah.
I think between the calcium and the normal part, there is some flap. So I think this is
Yeah,
the
it's a-
dissection.
Yeah.
Deep,
You definitely
Very
see it.
deep wall tear.
yeah, deep intimal tear.
Yeah.
But the point is, a lot of times, like the case we saw from London today, calcium hides the sections, so
Yes.
Yeah.
angiogram becomes important in those scenarios. So because of the attenuation artifact, and you can use chromoflow actually. If you have chromoflow in these systems, you can actually see blood going behind the calcium. So that shows you.
I
Yeah.
think that point bears repeating, that you don't just rely on one modality. You still want to use the two of them together, because you may see focal areas of disruption
balloon,
on
right.
Balloon
an IVUS,
3.5.
but the three-dimensional component sometimes just doesn't come out with these wafer-like cuts through it.
Good.
And what you see on the angiogram is that this is a long linear tear. We saw that in the case from the UK. What looked like a small disruption is actually a fairly long dissection. And this is the second one you've seen in a row.
Yeah, you're having problems
Give it
delivering
5,
because I think
15.
what it is now you've cracked the calcium. And I had the problem the other day. We are doing live case also. Everything went beautifully, and then we were going to stent the left main, and our left main, our guide was right there. The stent wouldn't go because the fracture you're hitting that part of the thing, and that's probably what happened here. You
Just now.
modified the
Yeah, exactly. So key is that, remember, to me, when the Anu has already done the IVL and that IVL deflated balloon did not go, and now same example was that your balloon stent did not go. So now we are dilating with the 3.5 balloon and then go to a little high pressure and then retry the stent.
So sometimes these are so complex that you have to put a guide extender in there to overcome them in conjunction with the balloon.
Go up here.
Yeah. Maybe a guideliner would help in this case.
Okay, go up here now. Good.
See, Your stent will still have problem going, but your balloon had problem going. But I think you get a good luminal gain here.
Yeah.
You'll be
12,
okay.
16. Yeah,
I think
18.
that calcium at the
Go,
distal
Mrs.
left
10.
main
Go
and
16.
LED junction
18.
is the trouble. Once you dilate with
Yeah.
this proximally, it will be
There's a nodule there.
Yes, yes,
Yeah,
there is no
that's
deal.
another thing. Yes. Good. Go up.
Anybody else on the panel have any comments on how they would handle this technically? Please speak up.
Kiski,
Yep.
where we see that tear, can you go back and show us
right
circumferential
there,
calcium?
right
How
there.
much
No,
is there?
they showed it right there.
Yeah, the calcium
Behind the
fracture
calcium.
we showed here.
I think there is no
But
more
it's
waste on the
360.
balloon.
Yeah,
and
Go.
maybe
no more,
it
yeah.
could be safe to deploy the stents, but either you push
16,
the catheter
18,
inside or you use a guide extension.
Yeah.
I would use a buddy wire. Would you consider using a
So
buddy
buddy wires,
the
I'm
buddy
suggesting,
wires,
wiggle wires,
Yeah.
guide extenders.
Yeah.
I think the thing I use is very simpler, is that once I get in there and dilate, I
Good,
take the unfurled balloon and
Good.
bring it back into the guide and then try to go down again.
We did. You see, that's what you just said. Anu heard it even before you said. She did it, and it goes in now. So now we can say for sure your stent will go in.
So you push the guide a little bit inside.
No,
If
we were
need to
more
be.
coaxial, I would say.
Coaxial, yeah. Go.
So now we'll go up with the guide.
Stent.
Sorry, stand.
And the pressure,
Now,
the pressure is okay. The pressure
you're
of the
telling-
patient is
pressure is, yeah, we are.
Sometimes the calciner is helpful for this situation.
Three,
Can we talk real quick about, you got two wires down here, you use a guide extension. If this is an 8 French guide, you could get a 6 French guide over guide liner or guide extender over one of the wires, right?
I know.
mean, that's one of the techniques that you can use for sequentially rotoblading.
That
things
would be
like
the way to do it that way. Most
Yeah.
of us obviously don't use eights anymore, but so you'd have to give up the side branch.
the guard's still ready.
I think it's the bias of that calcium. I think balloon in, guide extender in, quick
No,
stent.
yeah, I would put a second wire. They put your circ wire into the LED. That's what I would do.
It's
and
not going
most
to do it.
important to avoid long stents.
Yeah,
Well,
that's
this is
another
exactly
question
what
also.
happened
Yeah.
to
No,
us the other
Godzilla
day.
says.
I mean,
Yeah.
we were doing the case. This happened to us the other day, and we
Open.
take second wire, went over the other wire, nothing happened. So what we just did, inflate a balloon distally, took the guide extender, and made our case much easier. But I mean, those are the techniques, obviously, to change the bias with another wire, or just go bite the bullet and just inflate balloon and
Get us the balloon also.
Good point, because it seems paradoxical. I've done all this work. I've got a 175 burr, an aggressive rotoblader. I do a well-sized lithotripsy,
IVL,
so we didn't
yeah.
any pulses
No,
in.
no, later,
And now
later.
you think
Okay.
that the road is
Go.
clear and you're still having
You could
trouble.
have left the wire in the circ.
It's because of these
The
fractures
guideliner
and
will not go
irregular
in.
Go,
areas that
go,
you're
we tried.
No, no,
balloon
because
100%.
remember the
tipped
circ
in
wire
with
will
stents
stay
and
there.
No, no, no.
contact.
Outside,
cannot go
outside,
into the
outside.
LED.
Outside.
So you have to really have a
This has to
go
large
into the LED.
threshold for going on to the next
In
level.
7 French, you can
And
leave
that
the
would
wire
be a
outside.
guide
I told you
extender
other day.
or
I
double
did just
wire
other day.
or a wiggle wire.
Yeah. Go.
There's not
Number
only the tightness, but also the friction.
Get
It's a
the balloon.
6 French guide, yeah.
pass through this heavy.
No, 7.
Ah,
7
that's,
French.
then will not go.
Itself.
The
No,
6
no,
will
no,
go.
no, no. Oh, no, no,
What
it's
are
from
you guys
outside.
doing now?
Yeah. yeah.
No, we are just going with the Godzilla. We were just saying I took the circ wire out because if you want the Godzilla to get into the LED, you cannot have the circ wire there. But other thing is 6 French Godzilla, so you can go outside the circ wire
yeah, yeah.
and leave it there.
Yep.
Yeah, yeah. This was 7 French you opened, right? Yeah.
Yeah. So you have to have a 6 French. You can get through your 7 French guide. Otherwise, you need a 8 French.
Yeah.
But anyway, this one we do a little advancement.
And just a caution again for
Okay,
people
go.
in the audience that these are not good cases to do with 6 French
Good.
guides and things like
Yes.
that. Just for the
Good.
same reason.
Advanced.
You need to size up to
You want more?
accommodate multiple
No,
pieces
this,
of equipment.
I
It's
will,
a
I will.
garden
He has to go up. Go up.
We went up. Yeah. All right, we got about 7, 8 more minutes now. Deflate. Right? Because PK is getting ready for his endovascular case.
Huh? You can show
Huh?
you can show the provisional stenting. 3D app of the provisional stenting. Go up. Still don't know. Okay,
So,
deflate.
sometimes you have to inchworm, you have to do the proximal inflations, slide over that, push the balloon distal, slide over that. That's
Yep.
a sort of classic inchworm maneuver.
Okay. I don't know. Let's just do it now. You know what I want to do?
No,
Go
I'll tell
real
you
high
what to do.
pressure.
1 second. No, no, 1 second. Go further.
What's
Yeah,
the
here.
size
Low,
of
leave it
the
here.
Go
Leave
up
it
here.
here. Yeah, 3.5.
what size guide extender is that?
7.
7.
Yeah, I would just use guides a lot. It'll
Yeah,
go.
6. Yeah,
This is gonna have problem going.
good.
6
Go.
French, I
Now
would.
advance. Yeah. Now advance.
I
Cardillo
will, I
now.
will, I will, I will, I will. 1
Yeah,
second. See, the tip is also destroyed.
good.
Maybe
Right,
6
this
would
is
have gone
Good.
rather
I
than
know.
7. Okay, go.
And you can left the circumflex wire in that. Good.
No,
Yeah,
that
so you
means, you
needed
know
high
what?
pressure.
Yeah.
Good, good.
This
That's
type
fine. Yeah.
pressure, you know.
Yeah. Good. Good, good. Out, out, out. Good. Good, good, good.
Okay, let's
Good,
have
good,
the,
good. Good.
all you needed was a
Yeah, that's
24 atmosphere.
Yeah. So
Yeah.
key is that
now.
once you have tough cases, go to 22, 24. I know open NC balloon can be used, which is again very expensive, double the size of your cutting balloon, double the cost of the cutting balloon. But still, if you go with the IVL, it's still the 1/4 cost of the IVL. But the only thing is the IVL has a separate reimbursement. With the open NC, there is no separate reimbursement.
No, this is great. Now you are
Yeah.
cooking there, so it's
Yeah.
good. You talk about your bifurcation aid 3D modeling
Yeah.
things. You see the wires there. It looks amazing.
Yeah.
So, I mean, this is a tool really,
Good.
Anu has created, and it's
Do that.
very, very helpful when you do bifurcation stenting. Try
Good.
to understand,
Pull
Okay,
back.
let me go
you know,
cranial.
carina and
Yeah.
understanding how to perform kissing balloons and whether to do it or no, and then how to do different two stent techniques.
So what is the landing
So we're looking
area?
better here.
You have to
Okay,
pull
some
back.
die, some
Yeah.
die. I will pull back, I will pull back.
Yeah. Yeah.
So we
Yeah.
will be, if you see the original angiogram, I think just distal to the diag, but we
Yeah.
have to make sure we
Yeah.
come up to the ostium.
Yep.
Okay, so if you're covering the ostium, probably the cranial view is the best. Okay, some die there.
Yeah, important here on the ostium is to take a look at it in multiple views, right?
Yes.
Cranial and caudal.
But the stent is obstructing the flow, and so we have
It's
to
a 3.538 Zans.
Okay, some die.
Yeah. Good.
Don't see it well in
No,
any
but-
view.
Yeah.
I think maybe sometime just AP can give you a better view. Just AP, straight AP. Yes.
But you can estimate where to stop from previous angios.
Yeah.
Okay. Ready? Don't keep giving die like that.
Yeah.
I'll tell you. Okay. Now. Go.
You have to pull back more. That's okay.
No, I
Good.
think we're okay.
Good. Okay.
We can
Go
go
up.
gentle pressure, gentle pressure.
Huh?
Distal reference is
That's
3.1.
Okay. Go up.
This is more frustrating to pull back to nail the ostium, and all
Yeah.
of a sudden it comes back too far.
Yeah, 12 is good because distally it
Yeah.
is barely 3-5 vessel.
Mhm.
Down. Yeah.
Yep.
Now get us a 4-5, right? High pressure. Is that 4-5?
Yeah. What is the distal left main?
Left main is like a 4.1 vessel, not 4.5 vessel. Left
Huh?
main. 4.1 vessel left main.
4.1. So we have 4. That's what he said earlier. Good. Let's come out a little bit outside, go high pressure, and then we have 4. And then we remember our time will
Go
be
up,
up. You
go
want to show some of the calcific things? 20.
Okay, good.
Right?
Yeah.
Negative. Yeah.
You've shown that. You can show that calcific app where we have created with IVL rotational atherectomy, just like Jazz was mentioning, we have, algorithm to understand, how you can use what kind of technique at what you can show everything one by one. Ready?
Just proximally, we have to post more dilate with the 4O
Yes.
plus. Yeah. That we can do. So that's now become pot 4, maybe require 4.5. You want to just talk about your calcific? Yeah, that's okay. Enough.
Okay.
Case wise,
Do
is
it.
good. Yeah.
Do the post.
Yeah. That we can
So
do.
you can
Yeah.
see that calcificate, right? We showed the 3D. So
Bring to the
calcificate
main
was-
screen now.
There is ostial diag, but the diag was not that big.
Yeah. Ostial diag is okay. It was ostial circ we were worried about, which looks good. Yep.
Yeah, so this
Guys,
is
just
where
wanna
we
pass
are.
on. We've got about
Yeah,
3.5
calcificate.
minutes
Yep.
left.
Yep. Will be done.
Yeah, calcificate, which we wanted to show you, was the algorithm that we created. So here we would say for left main. You see that? So press. You can see for the left main, when you see left main, and then you have to know what is the calcium. So calcium, whether
Got
you
a
are
photo.
making a diagnosis based on
Check this
angiography
shit out.
or IVUS. So intracoronary imaging. So I think we did intracoronary imaging, but later on. And then also important is if you are considering side branch lesion, and then we decide whether it is a main vessel or no. Where did you put the thing?
So anyway, congratulations for the results, and the patient is had safely
Yeah.
tolerated the procedure.
Yeah.
You can show the final IVUS as well, the final apps.
Okay, so what
Yeah,
do we,
yeah,
Yeah,
stop,
yeah,
stop
no,
that. Go
but
back, go
yeah.
back. Yeah, this is, I think we added on to the updated calcificate, the IVL. And the biggest thing is the decision making. Okay, which like we discussed, do we do ROTA, OA, which where we
Go on.
said you can do the device based on what you're
2024.
comfortable with. Once you've done that, based
you.
on the imaging, then we decide whether you're doing the IVL. So if you're doing IVL, I think we all believe it has to be based on the vessel size, one-to-one vessel
Go on.
size, which we did here, 3.5, we went with a 3.5 and 4 atmosphere.
Negative.
Since it's left main, the question was, do you want to give all the pulse or wait? I think as long as we know the calcium arc or ring has been taken care and the dog bone is gone, we don't need to do more than that pulse until we have more studies to show that. But I think what we have seen, and we have seen in many other cases, is that you do see that some kind of a dissection that we are seeing in vessels. I think they left us.
And we are exactly to the 45th minute. This was
There,
earlier.
okay.
Then I post dilated with a 4O at 24 atmosphere with a pot, and look at this one.
I can't hear them.
Beautiful.
Do you IVUS?
We'll just do the
No,
IVUS
no,
to
hold
make
on,
sure
we'll do the
everything is good.
IVUS.
And circ remain good.
Show the final. No, I can't hear.
Yep. We are done?
And then show the
looks
final
like this.
final
like
app
the
slides.
Yeah.
The circ hung in very nicely as
Yep.
you predicted.
Yes.
The left main is maximally expanded. Do we have time
Yeah.
for a quick IVUS?
If you have time, we are ready with the IVUS.
Yeah, go.
Yeah, let's see the IVUS.
Let's do
Oh,
the
yeah,
IVUS.
yeah. All right.
Yeah. Show
Put
the
the
final
IVUS.
slides. Okay, so this is where we are. If you go to cardiologyapps.com, over 200,000 page views we have. We have 14 educational apps that we have released over the last 7-8 years. So last year we did device aid,
That's
and
fine.
more important is a clinical risk score, co-opt risk score for patients who are heart failure and who need to get a clip, so we can give them a risk score when we see these patients in our office. But I think most important, which people like, is bifurcate first, which is animation. 3D is 3D is animation. The other one is illustration. We have guide wire to understand what kind of guide wire to be chosen in CTO and non-CTO wires. And of course, I just showed the calcificate. There is one which is called complicate, which is very important for probably the early career physicians as well as fellows. All the important complications of the cath lab had been discussed. It's a web app.
IVUS
Or
is interesting.
80
Can
cases. Okay, now we can show the IVUS.
Okay, show the IVUS now to the main screen.
it's interesting. Okay, it's
Go.
not that. Okay.
No, the distal. It's
No, that's okay.
interesting.
I'm in the stand. We don't need
Okay,
distal.
start with
We did only for the left main. This
fine.
is we are showing for the left main only.
Yeah. Anyway,
Yeah.
area looks good. Yeah.
Yep.
And I covered also left main.
It's perfect.
Perfect.
Nailed
Yeah.
perfect right at the ostium. Well done.
All right. Very good, my friend. Fantastic. Thank you for giving us the opportunity. Yeah.
Yeah, Anu,
Thank you.
One,
Anu,
take it out.
Sabine, and the team, thank you very much. That was
Show the
that was
distal
an
edge of the
amazing
stand.
case. Thank you.